goal of today is really to go over sort of a pilot site summary. Um, this presentation is a living presentation, so I have drafted it. However, the real importance and the meat of it is really intended for you all to have a document that you can share with funders, or that even Dr. Dawson you can use for MOC credit, and really just use this however for your PCMH. You will also get a written one-page PDCA summary that you can use for HRSA, PCMH, Joint Commission, um, any quality partnership that you may have. And so I'll continue to talk about that in just a moment. I'm going to mute for just a second. I've got, my daughter is coming in, and so the dogs are going to bark. Hold on. All right, I'm so sorry about that. Let me start again. As I was saying, you can use this presentation in whatever way that works best for you all. Just a quick reminder, our pilot sites for cohort 2, not only were you all participating, but Pri-Med in Dayton, Ohio, and then an academic medical center in Des Moines, Iowa for Blank Children's. So some of the important milestones, and again, as we go over these, we would certainly ask for any corrections or additional things you would like to add here for implementation milestones. But we started, I looked back and we started the EHR build meetings in June of 2019. So that was pretty exciting. And we hosted or you all hosted us graciously August 7th for online training, or excuse me, in-person training, as well as mapping your workflow and setting up your scoring algorithm. By the 20th of August, you had your EHR build completed and were able to start collecting data, and went live on September 5th. So you had a really quick turnaround for go live after training. That's really the best practice that we'd like to see within 30 days. And we started our first coaching calls on October 23rd of 2019. It seems like forever ago. So your EHR build, well, I know that's a little bit fuzzy, but we had a great build, and it was done very quickly. We built in your screening as an orderable, that's a hard word to say, and just followed some of the processes that you already had for other screening and resulting forms. Anything else you'd like to say there, Dr. Dawson, or anything that you feel like needs to be changed or addressed?
No, I think that covers it well. Are we supposed to be seeing slides though, or?
Oh, yes. Are you not seeing slides?
Seeing slides.
Okay, that would be helpful. Hold on. Let me Let me get out of this. I must have lost my screen share.
Okay. Looks like it's coming up.
Okay.
Yeah. There we go.
All right. Good deal. Hold on. Let me get in the full presentation. I'm going to go back just a little bit. So these were the milestones that I went through, and then here's your actual build and some of the documentation components I talked through. I will also send you this so that if there are other additions you see, that we'll make those. So we consider the implementation of screening as a PDCA model or a PDSA model. And so the target population you selected were 3, 4, and 5-year-olds. And I already have made note that in May, I believe it was in May, that you started screening 6-year-olds. Is that correct, Dr. Dawson? That's what I had in my notes.
Yeah, I think that's correct.
Okay. When we first came to the site, you all talked about that rationale for screening really being that you wanted to integrate the being more of a trauma-informed clinic, and strengthen your Troy resources and community partnerships, and really leveraging your PCMH designation with behavioral health, which is awesome and amazing that you accomplished that. I know how difficult that is. I've done a PCMH application for multiple sites, but I've never had the added pressure of having the behavioral health integration component, and I know that's much harder. The rationale that you shared with us for really wanting to start with the younger population, the 3, 4, and 5-year-olds, was to really start focusing on trauma-focused cognitive behavioral therapy skills and training that you all had experienced for younger children, and really integrating that into your clinic. You guys started using the parent self-report of the ACE-Q. We could talk a little bit more about converting you over to the PEARLS tool if you would like to.
Yeah, I was actually looking at that because that's now on Chattis, and the questions are a little softer. So I don't know. It just reads more. I feel like we'll get more accurate answers on that one.
Yeah, I agree with you, and it is a validated tool. The only thing you would be missing, and of course, you could do whatever you wanted, and we just would pretend we don't know. Um, the ACE-Q is editable, so you're able to add those resilience questions at the bottom. The PEARLS tool is developed really to not edit, so you could stick those on there however you wanted to, and we would not ask any questions. When we identified your clinic scoring protocol, we designated positive scores as children who had 2 or 3 ACEs without symptoms as intermediate risk, and those with 2 to 3 ACEs with symptoms, or 4 or more with or without symptoms, as high risk. We then worked with you to identify interventions that were stratified based on the intermediate and high risk scores for either an internal case manager or social work intern referral for the intermediate, or an external referral as appropriate for high risk, or even giving patients those external referrals even if they were intermediate, but you felt they needed more assistance based on your clinical judgment. As we work through the PDCA model, the do component is really looking at how you implemented the screening, and you all asked the nurses to provide patient families with the What Are ACEs handout and the screener to introduce the concept, explain it, and then have the parents fill it out and complete it while they were in the exam room, and then for the nurses to hand off to the providers. Is that still your process, Dr. Dawson?
We have changed now with COVID and needing to go more paperless. So what we do now is that we actually have them completed on Chattis, but we still give them the what our ACEs the two handouts that we were doing before.
Great.
We give them anyway, and then we discuss the results. The provider discusses it. So
now, do they do the Chattis version in the clinic, or do they do it at home before?
It depends. They can do it at home before, but some of them like as well. I would say half, but
50-50.
Yeah.
Okay. So the key performance measures we looked at and the operational definitions we wrote for your clinic were to look at the percent of patients screened. So we looked at the number of patients who completed a questionnaire in a given month over the number of children. So this looked at the eligibility component, the number of children 3, 4, and 5, and then adding the 6-year-olds who had a well child visit in a given month. The second measure was looking at the percent of patients with the positive ACE score, and we looked at the high risk patients there. So again, those patients with the 4 or more with or without symptoms, or 2 and 3 with symptoms. We also looked at the percent of patients that had a referral. So again, looking at the number of patients that you made a referral to based on their ACE score, with the caveat, and that was over the number of patients that screened positive in a given month. But we subtracted the patients that were already in services, so you didn't have a falsely lower score. So the reason we came up with this methodology, just to remember back to our thinking back in the day, was to think about how patients, you probably intuited they already had ACEs, or you may have already actually known that and had referred them appropriately. So that's why we went ahead and subtracted them out of the score, even though once you formally started screening them, you had your intuition verified. That's why that measure looks at that. Now, we do have a fourth measure that we always collect for implementation of pilot sites, and that is the percent of patients that refuse screening. However, you are our first clinic who had no patients refuse ever. So that is just, I didn't even include the definition here because your data was 0, and we were very impressed with that, and it really spoke to how invested you all were in helping families to understand the importance. I do think that your process of going ahead and handing out the what are ACEs and what is toxic stress patient ed materials with the tool also helped you have a 0 refusal score. Not all clinics chose that process, so I really give you all kudos for that. I also want to share the good news that you had the highest screening rate of any of our cohort 1 or cohort 2 pilot sites. So excellent job. Of the patients that were eligible, you screened 99%, which is just amazing. Of those screened with the patients that had a positive score, just looking at the high risk was 16%. And those referred were 91%. All excellent findings. Also, our highest referral screening rates of any clinic. I just want to go back to this wonderful slide that Murnell pulled together for you when we had our training that had a comparison of US and Alabama rates. And if you look here, you can see that we can clearly see that based on the results of screening you all got of 16% with a positive, well, that's 2 to 3 ACEs without symptoms or 4 or more, a rate of 16% would be a little bit higher than what you're seeing from your overall Alabama statistics and US. So our hypothesis that the families in your community were experiencing more adverse events is truly founded in the data we have here. So I just share that slide with you for a comparison. Does that make sense? Because the blue part that's 26.3 is just 2 ACEs. So if we included 3 and 4, you know, that would have been a much different score. And looking at your rates of 16 with those higher scores really is clear that your hypothesis was absolutely correct. So the great news is Dr. Dawson has actually shared with me data beyond the 6 months that we required. And you have screened over 300 patients. In fact, as of August, the exact number I think was 321. We had 4 providers trained and screening throughout the pilot. Is that accurate to this day, Dr. Dawson?
So we had, let's see, what do we have now? We've had some turnover. So we've got, thank you. So one of our providers, Dr. Gal, left, and then we've got a new nurse practitioner who is just now starting to, will be seeing patients on her own. So
Great.
we'll still be at 4, just a different, but she wasn't here for the original training.
Okay, okay, very good. As I mentioned already, you achieved a significantly high screening rate. Even though your well visits declined significantly during COVID, you were also able to really have some innovations, creating the sensory suitcase as an identified need for having something available in the waiting room. I think was critical, and we still share that with clinics who call and talk to us, and everybody loves to hear about that, and we always give you all credit. We're trying to make sure that you don't get overwhelmed with a number of calls about it, but we've been trying to really understand what all has been included. And Dr. Dawson, you've been great with sharing information so that we can spread that wonderful and best practice to other groups. Mr. Busby told me a lot of other things that you're doing, but I also was very excited to hear in one of our last calls that in light of identifying a much higher need of more social determinant issues in your clinic, you've partnered with a local church to serve as an emergency food pantry as well, which is just wonderful. And I think that, you know, part of the assessment of looking at ACEs and social determinants is helpful, because then you see some of the needs in your community in a different way, and it facilitates a discussion about social determinants and ACEs in a different way that allows you to really meet the needs of the community in a broader way. So in 2017, the staff at the Center for Youth Wellness wrote a white paper about, you know, looking at what are the key areas of consideration when you get done with the pilot like this. How do you know if the clinic is ready to really spread their efforts in screening other ages, or even extending efforts out into the community, or do they need to kind of focus on revamping the workflow and sustaining their efforts? And we noticed 3 domains with about 6 key areas, and those are process factors, like how well you're able to innovate or adapt your screening abilities, and the ease of data collection and monitoring. In addition to that, there are staff factors, so looking at engagement and training of not only staff but your leaders, and then organizational factors such as fit with strategy or other infrastructure needs. And so, even just from a preliminary assessment, and I could add, and I will add much to this after hearing a little bit more of what you shared with us this afternoon at the beginning of the call, it's clear to me that you are in a very good position to spread your screening process. You've already developed some innovative patient-centered care interventions. You've already looked at you've already begun screening 6-year-olds, so you've already spread that and have brought on new staff and are continuing to see high rates of screening. And the areas that you serve in leadership in the community and all of the grants that you've achieved really help us to understand that there are good organizational factors and organizational alignment, as well as your PCMH behavioral health designation. So I want to share a couple of thoughts on next steps. I will get you this PowerPoint and a written one-page PDCA that you can utilize however you all feel appropriate. I can also share with you the full sustainability self-assessment. It has about 21 questions, and I can go over that with you, or you all can do a self-assessment. I would strongly encourage that you continue your data collection and monitoring. We have our last learning collaborative call for cohort 2 on October 15th, and I think it would be great to share some of the things you've learned and implemented and your future efforts with that group to give them some ideas on how they can achieve the wonderful accomplishments you have. And also, lastly, I want to just sort of share this ecosystem model that is really the new approach that CYW is taking with community partners. And so you guys are already doing a great deal of this, and you're talking about many of these things. So, and this is really Molly's area of expertise, and she leads these initiatives. And so I'll ask her to chime in after I give a brief description or add anything she feels like I've missed. But we feel that screening always needs to start in the clinic because of the medical component of assessing symptoms. But we are convicted and convinced that we also need to help patients and families and the community build out all the wraparound services that are needed after screening. And so we're really focusing on how do you better engage your community-based organizations to fit needs. And you guys have done you have a very innovative approach with that by simply bringing many of those community-based organizations in-house within your building, within your facility. So that's a great model. We also recognize that there needs to be a community coalition, and you've already started that as well. And so we're really working to help in other communities live out and create this ecosystem model where there's public policy change, education and training for community members, law enforcement, schools, thinking about trauma-informed reopening strategies for community-based organizations and schools and whatnot, and that just kind of leads back and helps to further educate and bring partnership between the clinic and community. So we have a couple of projects where we're working on an ecosystem. We'd love to talk to you all more about that if you're interested. We also, as Murnell mentioned, and Molly, have the learning management system courses. That is sort of a bread and butter revenue stream for us at Center for Youth Wellness. So we would be very interested in talking to you about how we might be able to partner with you, Dr. Dawson, to share a handout with your American Academy of Pediatrics organization, just if there's interest in individuals taking those courses. They're very reasonably cost CEU and MOC credit, so a lot of bang for your buck there. And it's just another nice way to spread the concept of screening throughout the country. So we'd like to talk to you more about that. And then just, Molly, do you have any other thoughts or wisdom you would like to share about the ecosystem?
No, I think really, Carissa, you got it. And I sort of mentioned it too when I was talking about, the work that we're doing. And nope, I think you got it.
Molly, I've heard your spiel a lot, so I'm getting pretty good at it.
You're doing great.
Do you guys have other questions or thoughts for us? Anything else you would like corrected or added to this presentation so that it can be useful to you as you move forward with funders and whatnot?
I think the only thing I was thinking on the age group that we chose, we started with the 3-year-olds because they could do the TFCBT, and I think we were focusing on that age group somewhat because there weren't a whole lot of great services for them, and so although. Yeah, and we still don't have TFCBT here, but we've learned about other approaches as well. And we've got CPP providers, so that's good as well. But yeah, just the lack of, that just being a difficult group to get services and get them the help that they need, but also, lots of great potential for intervention. So we really, once we targeted that group, it became and that's kind of where I've explored more, how I can better help them and how we can build these services here, because we didn't have a ton of places to send them initially, but we're since we focused on that group, infant early childhood mental health is starting to explode in our, not because of us, but it kind of all came together. So it's a really nice that we were able to focus in on that group, and now we're starting to make those associations where we can build that referral network and also build our internal network as well. So
very good, very good.
And then I was thinking about the ecosystem thing too, and I think, and I'll definitely talk about it on the call, but what we've done is really just started meeting, and it's interesting because some meetings we have a bunch of people, some meetings we don't have that many, but we always have a really interesting conversation. There's almost always someone new. And so I think the encouraging thing is just being available and having a time for people to gather. You're gonna learn so much about what's going on and pique people's interest and help them to that's to make it a trauma-informed community. Really just having a meeting time and letting people show up and having discussion is kind of been our approach, rather than having the mayor and the whole police force and the city council approving ordinances. I think we'll get there, but for us it's been more grassroots and finding people who are interested and building from there and kind of reaching out to the service providers. But as more people come, we get more ideas about how to expand our reach and how to involve the community more. So it's been an interesting journey.
Absolutely. And I, we'd really like to hear more about that as well. The one thing I did want to offer you, as you bring your care, was it a care coordinator or a case manager on with the grant? What is
She,
her title?
well, her title is going to be she's the Healthy Steps Specialist, but so she'll be working with families in the clinic during well child visits to teach them about development and help with any struggles from postpartum depression to um, you know, inappropriate harsh discipline, all those sorts of things. So
Great. We do have a taped webinar on, it was really designed for care coordinators and patient navigators around talking to families about social determinants and ACEs. And we'd be happy to share that with you if you would like her to look at that. And if she had any follow-up questions, I'd be happy to talk to her as a resource. But if that's not needed, that's fine too. But just want to make you aware of that as an option for some training for her that we could provide to you for free.
yeah, that'd be great. Thank you.
Okay, good deal. Um,
Can I ask a question really quickly?
Absolutely.
One of the things that we're looking at for our clinic and just the work that we're doing is electronic social service resource locators. So things like 1 Degree, Aunt Bertha, I think those are both California based, Unite Us, things like that. Are you all using anything like that? Or do you plan to use anything like that in the future?
We don't have anything electronic. A part of our Healthy Steps thing is we have to have a resource directory, and so that will be, but it won't be like a search engine type thing. It'll be more of but we'll post that on we have a resource directory already. We just need to amp it up and post it. So it'll be, but it's still more like a PDF type document. We do have Help Me Grow Alabama, and so we use that as a resource to refer parents to help them contact resources, but we're not currently using any electronic social service engine. I don't know.
Yeah, I'm sorry, Dr. Dawson, I was going to say, so, as a part of your grant, if you would like, or if you want to think about having us do a needs assessment around that and provide you some information, we've found in our ecosystem model that having that type of an electronic platform available has really made all the difference for not only clinics but also the community-based organizations. We've done a lot of demos with, I think, every provider out there that has that type of service, and so we're really working to try to help organizations integrate that into their model, to ease with referrals, to help close the loop on referrals. And many of these systems have the referral tracking component that you would need for PCMH, so that you could claim your kids with a higher ACE score as one of your special populations. So, we'd certainly be interested in talking to you about that if that was something that you felt would be appropriate.
Okay. Yeah, we'll definitely look into that as well.
Great. Donna and Mr. Busby, any questions or any other thoughts? We have just a few more minutes. Anything else you would like us to know or understand or even include that you feel like we missed in this presentation?
No, the only thing is when we do receive the PowerPoint that you're going to send us, will we be able to make our own edits or additions to that PowerPoint? Is it ours to do whatever with?
Absolutely. Absolutely.
Very good. Thank you.
And I will send the written PDCA in a Word document as well, so you can edit that.
Okay.
Sounds good.
Good deal.
Carissa, it's Murnell. I just wanted to also add, for Dr. Dawson and your team. If there are any changes that you do make, it would be great to share that with us so we see what progress, and having updated version on hand as well. That would be great.
Okay.
Wonderful. Well, thank you all so much for your time. I'm going to miss our coaching calls, but I will always be here for you if you ever need anything. You know that certainly, I know you have Murnell's email and I know you have mine, and Molly as well. We would be thrilled and delighted to hear from you and happy to help in any way. And you can anticipate getting this final presentation a little bit after the October 15th Learning Collaborative call. And also I'll be able to share like a one-pager about the other program's results. So I'm finishing their calls between now and October 15th. And the only reason it'll be until October 15th is in case there's anything important that comes out of that learning collaborative call, I want to be able to share that. But you'll be able to see how your outcomes compared to theirs and some of their key learnings as well.
Okay, great. And then, so do we continue to submit data or just track it ourselves, or?
You can just track it yourselves. You don't have to send it to me.
Okay, thank you.
You can if you want to, but you don't have to.
Good.
I never like to cut off data, but you know, we really appreciate you all. It's been a pleasure working with you. We're not saying goodbye because we're gonna touch base a couple more times between now and the end of October, and we look forward to you participating on that call. And we're always here for you. But it has been a true honor working with you. You have really inspired us with everything that you've done and accomplished, and the ways you've gone above and beyond to serve your community.
Well, thank you. It's been great working with y'all too.
All right. You have a wonderful afternoon.
You too.
All right. Bye-bye.
Thank you.